the height of people in Kansas, let's say the average is 6 feet, and the height of people in California, let's say the average is 5 feet. Can I predict your, James's height, since I know that you live in Kansas? Well, no, not really, because there's a lot of other factors that go into it that isn't just categorized by which state we're in.
Typically, the guidelines will say you're initiating, for example, like a statin therapy. Once somebody crosses a certain threshold, let's say 10% risk over the next 10 years, or USPTF guidelines, which are applied at a population level. How do you take that and then also look at, let's say, a patient's individual factors that maybe everybody's going to be different, so no guideline is going to fit perfectly to every single patient?
Yeah, I think you articulated it well. There's population specific data, and then there's individualized predictive data, and those don't necessarily align, while they often do align and can be used for clinicians. I kind of think of it in this idea of ecological fallacy. And so you can't, it's the idea that you can't apply like a population level average to an individual. So like maybe there's an example of, we're trying to compare heights between, you're in Kansas and I'm in California. So the height of people in Kansas, let's say the average is 6 feet, and the height of people in California, let's say the average is 5 feet. Can I predict your, James's height, since I know that you live in Kansas? Well, no, not really, because there's a lot of other factors that go into it that isn't just categorized by which state we're in. Like maybe if I'm a male or a female, it's going to have a big difference on my height. It's kind of a binomial distribution. Men are generally taller than women, and so the men would be aggregated up here and the women would be aggregated down here. Age is also another example. If I'm 5 or if I'm 15 years old, that's going to have a big impact on my height, kind of unrelated to the state that I'm in. So this idea of ecological fallacy is you can't apply these group averages to individual patients. It's maybe a good place to start, but there's all these other factors that you're not quite aware of. And kind of another point on that is an average isn't like diagnostic of an entire group. The average is just, what it is the average. And so there's a bell curve of, going back to this example of heights, say you're at the average, you're at the 50% mark for height. Depending on how much those bell curves overlap, there could be still 40% of people in California who are still taller than you. And so I might be in that 40%. So you can't really say that you're taller than me just because our states have differences in the average. So I think this is an important concept to think about when looking at population health guidelines. The USPSTF, the United States Preventive Services Task Force, does put these together. And so it's a national guideline. So it's for people throughout the United States, and they evaluate specific diseases and well-defined prevention services, and then look at the evidence for specific health outcomes. And I think it's a good place to start for clinicians, especially busy clinicians who are seeing lots of patients and need to stay up with the evidence. But it's not necessarily the best for individualized care for a few different reasons. Before I get into that, I think one important thing to note about the USPSTF is they don't intake cost data. I always found that a little bit interesting. They're only looking at health outcomes. I think there should be probably an organization that does pull in cost data, because costs are becoming exorbitant in the United States. But just so everybody knows that they're not looking at costs at all. They're just purely looking for health outcomes. But one of the limitations is that it's focused on younger patients and leaves a lot of the older patients out of the data that is used for this guideline production. Partially that's because as you age, the diseases become multifactorial and have multiple different interventions. So it's hard to parse out those risk factors. Another is a lot of research kind of cuts off adults at 65. So it's 18-year-olds to 65-year-olds, and we're not getting that data for those after 65. And I think it's also a bias towards quantitative data over the qualitative data. And so we look a lot at mortality instead of maybe looking more at like quality adjusted years of living, or looking more at the quality of your life. So I think, especially for older patients, the USPSTF has some limitations. I think there's also a lot of it is focused on secondary prevention, so identifying disease, and not so much on primary prevention. Kind of going back to the same thing with the older adults. I think this is because of a selection bias of the data. I think a lot of the research is about identifying disease and not so much about preventing it. And so that data doesn't get incorporated into these guidelines. And then, just by nature of it being something that looks at all the evidence and then develops these meta-analyses, which is basically a single score based on what all the different evidence showed, it lags behind kind of the current clinical care quite a bit, because it waits for research to get published and then waits for enough of that research to get published that they can put together this analysis. So it doesn't really include some of the cutting edge stuff, some of the really innovative stuff, and then some of the more rare stuff that it's hard to publish on. So I think it's a good place to start. And I like to go there and find articles to go to, but I don't let it dictate my individualized care to patients. I think, your care goal should really be specific to what the patient wants through a conversation with them. Do you care about the length of time that you live? Do you care about the quality, or is it somewhere in between that?
Yeah, I think that's a really fair assessment, especially the positive that it's a great place to start and a great place to find some of those larger trials that they're looking at, and some of those, meta-analyses like you mentioned. And then also, I didn't know that they didn't actually take the financial data or the financial burden into account there. It's strictly looking at, outcomes data. So that was really interesting to me.